Hey, thanks for coming, everybody. I am the second in the series of multidisciplinary case conferences, and my topic today is drugs of abuse and toxicology. Toxicology is a huge area. I had to kind of narrow it down to a little bit. This is a newly minted talk, conjured up this week, so should be up to date. There's a lot of drug testing in society, okay, so it's a huge business. The military tests recruits and random tests, so their force is ready. There aren't people on drugs in the military. Criminal justice system, another big area of testing before and during incarceration. Public sector, the Department of Transportation, so people that are drivers in car fatalities are automatically tested by law, for alcohol at least. Train accidents, you don't want your train conductor high on cocaine, as the Grateful Dead song is, Casey Jones. And Ronald Reagan, Big Ron, signed in 1986 a drug-free federal workforce regulation to keep the federal employees drug-free. And then in private sector employees, there's a lot of testing that goes on that's really huge. And then in professional and Olympic athletes and other athletes, there's testing for performance-enhancing drugs, and we won't really talk about that today. The specimen of choice in drugs of abuse and drugs in general, other than, say, therapeutic drugs or certain other things that I'll mention later, is urine. It's easily collected, it's non-invasive, it concentrates the drug more than you would have in the blood, and it is detected longer than in the blood. It's technologically simple, and we can have a rapid turnaround time, and it's confirmable by gas chromatography mass spectroscopy. Our in-house rapid urine drug screen contains these analytes, these drugs. This is a screen, okay? Sometimes you get false positive, sometimes you get false negative, sometimes you get a negative reaction when you think you should have a positive because certain parent drugs kick down to their metabolites and you don't pick them up. For example, clonazepam goes to a metabolite fairly rapidly, and you might not pick that up. Tramadol, some of these newer, weaker opiates might not be picked up. But for the most part, this is a pretty good screen. It takes 9 minutes to do from the run time where the sample's put on until the result comes out. So it's useful in the ED. It's not as useful in monitoring for compliance and diversion, because sometimes you get discrepant results on the screen, and that's why some places like pain clinics use a third party which tests the urine more extensively, and they use some different techniques. This technique that we have in-house is called an ELISA. It's an enzyme-linked immunosorbent assay, and it's got pretty good sensitivity down the line. So that's one good thing. I want to give you a little historical perspective on some of these drugs because it's interesting, I think. Meth and amphetamines were discovered accidentally in the 1920s because there was supposedly a shortage of ephedrine for asthmatics, and ephedrine is a stimulant, it causes your heart to race, but also opens your bronchioles, so it was used in asthmatics for a long time. Ephedrine's been outlawed in this country since 2003. And you might also remember the weight loss drug fen-phen, which was associated with cardiac valve abnormalities. And I actually had a case of fen-phen death, a woman that died because of mitral valve insufficiency because she was on fen-phen for weight loss. Part of the fen is outlawed, the other half of it is still available. In the 20s, accidentally, while these guys were trying to find ephedrine or synthesize it, because there wasn't supposedly enough natural sources, a UCLA grad student isolated amphetamine. About the same time, a Japanese chemist, Ogato, isolated methamphetamine. And ephedrine was finally isolated in 1929, but that perceived shortage never developed. Amphetamines were used both by the Allied and Axis troops in World War II. And you've seen some pictures of pretty strung out troops that have been on the field for days. And this did become a social problem in the 60s. And clinically, amphetamines are used to treat conditions such as narcolepsy and attention deficit disorder. Now, methamphetamine, as of today, has been and is a widespread medical problem due to the ease of manufacture and readily availability. So what does meth do? At the synapse, in these vesicles, there's dopamine that's stored. It releases the dopamine into the synapse, and the postsynaptic neuron is flooded with dopamine, and you get a rush and a lot of energy. As far as metabolism goes, if you get a positive amphetamine, that doesn't mean the patient's not taking meth, because meth is metabolized to amphetamine. And if it's been a while, the methamphetamine will metabolize to amphetamine, but usually there's some parent drug available also to detect. As far as the speed run goes, these are the people that, they generally smoke it. Some people inject it. This is a meth pipe I took off a guy who was in the ditch on Highway 210 in Wilkin County, frozen solid in a small pickup. And in his hands there was something, but nobody knew what it was. And I pried it up. I pried his hands open and got that pipe out of there. So basically, you heat that up on the bottom. It vaporizes. You hold down on the top and inhale it. It hits the brain in 7 seconds, and people are high. It's got 90% bioavailability, which is pretty good. And injection is like 100% bioavailability. So the duration of action runs from 6 to 12 hours and up to 24. Half-life of 10 hours, and detectable in urine for up to 3 days after the last use. So the stages of a speed run starts with the euphoric rush, and then people start to kind of mellow out, and they smoke more, and they not get quite as good of a rush, but it sort of starts wearing off, and then this can go on for 3 to 5 days or more with no sleep. And I've heard of people that have been up for 9 days, 20 days, and you can imagine that long a time with no sleep is a problem. You start seeing things, you get psychotic, you get paranoid, and you've seen these people, you've seen these tweakers in the convenience store. They're usually looking for some kind of sugary thing like pop, and they're like, you know, and they might be doing weird stuff, and you can kind of tell someone that's tweaking on meth. I can spot them a mile away. Oopsie. So what is this toxidrome all about? People are keyed up. They have racing thoughts, pressured speech. A lot of times when you're talking to these people, you can't really get a word in because they interrupt you and they want to just talk and babble. They may be tachycardic, hypertensive, elevated temperature. All these other things: restlessness, tremulous, excited, talkative, bruxism, loss of appetite, insomnia, dry mouth, irritable, manic, paranoid, psychotic. Medical complications, seen a lot of these. Death secondary to trauma. Most things I've seen are cardiac arrhythmias. Sometimes people that are on meth. I had a recent case of a guy with hypertensive cardiomyopathy who was also on meth, and he died from probably his hypertensive hypertensive cardiomyopathy, but also meth added to it. May have seizures, hyperthermia, rhabdomyolysis, which can cause kidney problems. We recently had a case here where a patient showed up. The guy was in his 40s and was, I believe, he was unresponsive, and he ended up in Sanford, and he had multi-organ system failure and died from meth toxicity, and his meth level was pretty high. And meth mouth, what is this all about? Okay, so why do these people have such crappy teeth? One of the reasons is because they have a dry mouth, and saliva protects your teeth from decay. And also, meth itself is acidic, so if you're inhaling it, plus there's poor hygiene involved. And one other thing I'm not thinking of at the moment, one other.
Vasoconstriction?
That's probably right. Vasoconstriction.
Eat sugar?
Sugar. Yeah, they love the sugary drinks for some reason. So you see some of these young people with bad teeth, you know, and they're high on meth. And you've also seen another feature of that's a clue. So you try to collect clues. Are meth sores and imaginary bugs. Sometimes people think they have bugs under their skin and they don't, and but then they start picking at them, and you know, it's not uncommon to see that. And then you've also seen the pictures where people start out, you know, say a beautiful young person, and then in about a year they're looking pretty rough, you know, where so their ages accelerate, they look aged and accelerate, and they're really hard on their bodies. That's meth. Opiates. Opiates have been in use since antiquity, coming from the poppy seed. The poppy symbolized sleep and occasionally everlasting sleep, which means an overdose. But Socrates was sentenced to death in 399. And he was punished with drinking a mixture of hemlock, which is a poisonous plant, and opium, because he was thought to be corrupting the minds of youth. And then in the Middle Ages, later Middle Ages, laudanum was used, and beyond that as a tincture of opium. If you were a doctor back in the 1800s and you didn't use opium, you weren't really a good doctor. So morphine was isolated in 1805 and widely used in medical practice. Heroin was synthesized in 1874. It was marketed as a cough suppressant, and it was considered safer than codeine by Bayer. And a lot of these people that isolated these compounds are, you'll recognize their names because they're drug companies now. Bayer, Merck, Roche, some of these other companies. It's kind of interesting. And it was widely used into the early 1920s when the AMA stepped in and said, hey, this is not working out. Laudanum is really messing people up. And the AMA stepped in, and there was legislation to regulate it. But you could get, this was good for, was marketed as a cough suppressant for the adults and a baby.
I bet it was for colic.
Yeah, colic, whatever, there was any other problem, you know, not sleeping. So, yeah, this could be another drug thing, I don't know, drug guy. So the problem has been solved. So these are some of the common opiate agents that we see. But let me back up one slide. Or two slides. I'm a little tired of hearing about the doctor's role in the opioid addiction process, because we didn't start that. And the media and nobody can seem to remember what the real initiator was of the opioid deal was. And part of it was this Mitchell Max, president of the American Pain Association, stated that therapeutic use of opiate analgesics rarely results in addiction. And then the Joint Commission got involved and said, well, let's make this the fifth vital sign. So, you know, and you should be treating it because you doctors aren't, you providers and doctors aren't treating pain properly, and you should be using more opiates. So the pharmaceutical companies like Purdue, who manufactured OxyContin, they've sold out since, but there's still lawsuits going on, and a ton of lawsuits against the manufacturers, and they haven't yet attacked physicians that I know of. But so that's when the pain chart was developed. When I was in training, there was no pain chart, so this opioid crisis then ensues, and I think the manufacturers were saying, okay, the government's saying, treat pain, we're going to make them, and there billions of pills were made, and billions of pills were prescribed. And as we found out, it was a problem. So, and sometimes prescribers get the blame on, I believe, not, some prescribers went over the top to make some cash, okay? Those were unscrupulous people, nobody in this room. So, the common agents are heroin, morphine, Dilaudid, Demerol, oxycodone, codeine, fentanyl, and propoxphine, which was an earlier drug. Fentanyl is not picked up on our urine drug screen, and if you want to check for it, you have to order it separately. It's a send out, so that's not part of our drug screen. We're trying to get it on there, and we're going to continue to work on that. Fentanyl can be abused in a lot of ways. Duragesic patches, chewed, smoked, made into a liquid and injected, and there's also some super powerful fentanyl derivatives that have been made in Asia, came through Canada, down into the U.S. And what is the name of that?
Like carfentanil.
Yeah, carfentanil and those types of things. It takes a very little amount to die. And some of these people are multiple offenders. They've been they've overdosed. They've been resuscitated, and then they overdose again and eventually die. Opioid metabolism is a little bit busy. For example, codeine does eventually, some of it does make morphine, a lot of these things. Okay, heroin is quickly transitioned in the body to morphine. Oxycodone has these metabolites, oxymorphone, noroxymorphone. Anyway, it's kind of interesting. So like sometimes when I do a drug screen and I'll send it to MedTox or the state, the BCA, which is super slow, so I use MedTox more often. I'll get a lot of these things, and then you kind of add them up, and then I look on a chart to see if they're in the therapeutic, toxic, or lethal range, and that helps determine what to put on the death certificate. The toxidrome for opiates, high addictive potential, marketed as not being addictive, especially in the OxyContin situation. Pinpoint pupils, slower breathing rate and amount per breath. Constipation slows the bowel down. Naloxone reverses it. The deaths are almost always due to respiratory depression. Sometimes, you know, opiates do affect your ability to operate machinery and drive cars, and also make some bad choices. And it's often utilized with other drugs too. When you withdraw from opioids, it's from what I can tell, it really sucks. But it doesn't last that long. So you can, you know, treat that with different things. And I know you guys, I know like, for example, Dr. Money and Dr. Vukinich have a protocol probably for this. And it's you can go cold turkey. It's just a drag, but after a few days you're okay. So it's not like you're going to die from it. So opiates may be found in the urine 6 to 8 days after the last use. That's opiates. If you have any questions or comments, please feel free to throw them out. Coca has been used for a long time, and it's a plant from the New World, okay? So it wasn't something that the Africans or the Asians or the Europeans got until they got over here. The Spaniards got it from the Peruvians, and they found out the Peruvian Indians, they would chew the coca plant in religious ceremonies. They didn't really have any problems, but the one thing was when the Spaniards made the Peruvian Indians, you know, gold mine, they couldn't really do their labor unless they were, you know, chewing the coca plant. It was purified in 1860, and it was part of the original recipe of Coca-Cola in 1886. Originally, Coca-Cola had not the coca, and this had nothing to do with cocoa, like chocolate, but that's a different deal. And it was with wine and this cola, which had some caffeine in it. But then the coca was in it. But then that was changed. Sigmund Freud was a big fan of of cocaine rather, and recommended it as a remedy for a host of conditions, some that are not even recognized as diseases today. And it was found to be a local anesthetic, which it could still be used as. Back in the 80s, body packers syndrome occurred with people that had cocaine-filled condoms in their intestines. They swallowed a whole bunch of them tied together, and if one would rupture, they would die. And the deaths in the U.S. Increased dramatically in the 1980s. I don't know that cocaine it's maybe not necessarily a lot of it's cut and with other things, and it's not as prevalent as it used to be, although we do see it in some cases. At one point in time, there was a guy, Mariani, who developed cocoa wine. And so if you had fatigue of mind and body, which who doesn't, and all these other things, why not? So that turned out to be a bad idea as people had developed complications. But what happens is cocaine prevents the reuptake of dopamine, resulting in stimulation of these receptors. So you get this euphoric rush. It doesn't last that long, so that's why there's this compulsive need to keep taking it. And some people snort it, some people smoke it. You may remember freebasing, where people would dissolve it in ether and smoke it, and that's how the comedian Richard Pryor got burned, and you know, even an experienced chemist probably wouldn't try to do that too much. But it can be taken orally, intranasally, intravenously, or in inhalation. So cocaine is metabolized to, before we go into that, let's go into this. Intense stimulant. So that's why it's repetitively used. It's a fairly short duration. It's a lot shorter than meth. So I don't think it's as popular as meth, clearly. You can get a delirium associated with this, hyperthermia, agitation, and sudden death. There's really no level of cocaine that is considered safe. You can die of a cardiac arrhythmia from any level of cocaine. Chronic users oftentimes comes off as quite self-confident, egocentric, much like a radiologist, but also may become coked out with difficult concentrating and remembering, short-tempered, aggressive, suspicious, and may develop paranoid psychosis.
Like
You know.
pathologist.
Similar to a radiology situation. IV route is sometimes called mainlining, produces 100% bioavailability, but smoking is a lot easier and snorting is a lot easier too. You get pretty high bioavailability this way as well. And these cocaine and the benzylglycine or golkine or whatever it is may be detected in urine 4 days after last use. Snorting cocaine can result in damage to the nasal septum, where you get a perforated nasal septum. Yeah, and yeah, it's these people that are coked out really just get kind of despondent. One thing I should mention, I don't have it in my talk, are bath salts. Bath salts are not really bath salts. They're made to look like bath salts, just to disguise them. They've been what could I say? They're outlawed, but they're like a combination of cocaine and meth. And these people that are on bath salts are very aggressive, and if they show up here, it's probably going to be a Code Armstrong. So let's move on to benzos. It's pretty hard to overdose on benzos, although I have seen it. A guy took, not too long ago, way too many Ambiens, full bottle, and died. And also took some tricyclic amitriptyline, that was for insomnia as well, and died. Dr. LaRoche discovered this in Poland in the 30s. And then this first came out as Librium in 1960 and was approved by the FDA. And it's used for a lot of things: anxiety, insomnia, seizures, alcohol withdrawal, sedation, and surgery. And dependence can occur within 4 weeks of initiating therapy, and how this works is it inhibits the action of potentiating the inhibitory action of GABA. So a lot of times it's used with other drugs, including meth and alcohol, and it results in CNS depression. But by itself, it's pretty hard to overdose on those. Cannabis, a psychoactive product of the cannabis sativa plant. It's been used for over 4,000 years for its euphoric effects. It's dose dependent on the mixture of how much of a stimulant it is or a depressant. At a lower dose, it's more of a stimulant. It gives you a lot of energy, gets you euphoric, gets you relaxed. If you take more of it, you get kind of tired and not as, probably higher, but more just less interactive. But the main effects are euphoria, relaxation, altered time perception, lack of concentration, impaired learning and memory, mood changes, paranoia, dry mouth, and increased appetite. There is a part of the cannabis plant that, and it's a pretty big part of it, it's called CBD. It's a phytocannabinoid, and it's been marketed to reduce pain, but it doesn't get you high, okay? So like some people, like I know, what are those people that adjust you? Chiropractors? yeah, chiropractors, they might come up with something like this. I don't think, yeah, and I think it's still available.
They sell it at Meadow Farm Foods.
Oh, is that Meadow Farm?
A lot of my patients get it there. Or you could buy it online.
Sure, interesting. There's a lot of things that are available at like these head shops. There's this Mitaranga species, which is called kratom. It's kind of an opioid agonist. There's other things also. Sometimes you're not really sure what you're getting. But interestingly, most cannabis you think about is like Cheech and Chong, okay, where they're smoking big joints. But we're all, of course, everyone knows about brownies and cookies. That has a low, it takes longer for that to work. But now, in these states where it's become legal, 11 states, the vaping has really been common. So you don't have that odor of cannabis. And this vaping comes in a little device. It's a little tube with purified THC, and then it's connected to a device that heats it up, and then you can inhale it and get it into a vaporized form. That's becoming more and more common, I think. Problem with the cannabis isn't so much in adults per se. I mean, unless you're at work. It's more associated with problems with women that use it in pregnancy. Frequently, more often than not, have a hyperactive baby with attention deficit. And so it's not to be used during pregnancy. It's not to be used in adolescence because the developing brain is affected by cannabis in different ways. And one of the things it can do in people that are predisposed to developing schizophrenia, it can start that process. And we've seen that here, and I know of a person that had that happen to him. And I think it was a trigger, although he did run in his family. So this is a problem for, adult, not so much adults, but for adolescents who have developing brains going on, and pregnant women. Okay, it's fat soluble, so it can be stored in fat and detected for up to 30 to 60 days. That would be in a heavy user. Passive inhalation is not a valid explanation for a positive result in a urine test. People say, oh yeah, I was at this party and people were smoking weed and I just inhaled it and now I have a positive drug test. That's not real. Inhalants, these are volatile organic compounds. Abuse is most common in adolescents. Effects are similar to those caused by ethanol, although there's more nausea associated with them. But the common inhalants are toluene, like in paint and adhesives. You used to get those whiteouts. People could inhale those. You could go and get a one of those aerosols and get high from that. Refrigerants, butane, even from a Bic lighter. And as far as testing for this, Mayo Clinic has a volatile screen that's performed on blood. This is one of the tests that is performed on blood, not urine. Metals. Mayo does have a heavy metal screen. I occasionally get people that say, I think this person's been poisoned, so I usually end up collecting some hair and some nails and stuff, and some blood, and just in case it needs to be tested. I really haven't discovered any poisonings per se, but some of the metals we're talking about, aluminum, arsenic, iron, mercury, lithium, lead, and thallium. Okay, that's another category. Hallucinogens, LSD, mushrooms, psilocybin, peyote, mescaline. These people are generally awake but detached, distracted. They have perceptual defects. It might be like, ooh, I'm in Alice in Wonderland deal. Tachycardic and diaphoretic. Medical complications from this are few unless somebody does something stupid like walks off the edge of a building. So treatment is by minimizing sensory stimulation and benzos. Ecstasy is a hallucinogenic amphetamine. The MA is methamphetamine, and it allows you to like party all night at like these dance parties, clubs. PCP, phencyclidine or angel dust, a dissociative anesthetic or depersonalizing agent. That was used more in the 80s. We don't see very much of it, although these people can get really agitated and violent. Has a 24-hour half-life and is detectable in urine for 5 days after use. So GHB, gamma hydroxybutyric acid, is a structural analog and metabolite of GABA. It's considered a date rape drug. It causes dose-related CNS depression, and this GHB coma typically lasts for 1 to 2 hours with full recovery by 8 hours. Problem is, it's detectable in blood and urine for only 2 hours to 6 hours respectively after ingestion. So the rapist is, you know, you say, oh, this person was just drunk, you know, and it's hard to detect this. So you suspect it if there's a history of vomiting, incontinence, unexplained gap in memory of events, or history of unintended drinks in any public place. Yeah, you don't want to leave your drink hanging around. Yeah. It's Dr. Smith. Yeah, put that person in the cooler, please. Thank you. Meconium. Meconium is like a historical accumulation of drug metabolites and an indicator of maternal drug use during pregnancy. It identifies amphetamines, opiates, metabolites of cocaine and marijuana. Okay. And it forms in the first trimester of pregnancy and is the first fecal material passed by the neonate. And we have sent some cases out, as Dr. Norgard knows. And results of this test can cause illegal separation of the infant from its mother. Therefore, chain of custody testing is recommended. That might be it. And I don't know. Yeah, I wanted to go 45 minutes so we could have time to just talk. If there's any questions or anything. Trying to think of some things I left out. Yeah. That's kind of drugs of abuse in a nutshell. Now, among our colleagues, we do have, I believe, a PhD, a clandestine PhD that was obtained online by one of our doctors, and he and I collaborated on a case of metabolic acidosis in a young male who came in unresponsive, and it was a high anion gap metabolic acidosis, and then he wanted me to look at the urine. I was like, what? Okay, and there were oxalate crystals in there. So what was that compound that that person ingested? And they were in renal failure.
Ethylene glycol.
Yes, antifreeze, ethylene glycol. And the individual I'm referring to is none other than Dr. Sampson, who happens to be in the audience today, and I would refer additional questions to him, since, you know, I don't know, he doesn't make a big deal of it, but he does have a PhD in tox, which I'm no expert in toxicology. You don't get a lot of training in it, and there are toxicologists, and something we could think about doing. I know it's nice to have the rapid urine drug screen right away, but at pain clinics it's done differently with a third party, where you get send the test out, and there's a lot more information involved, like when they may have taken their last dose, any metabolites that are in there. And these are all done by, they're confirmed by gas chromatography, mass spectroscopy, which is like a fingerprint of the drug, so that's 100% perfect. It's not a false positive, not a false negative with GCMS. You know, so that's why we consider our thing, our test a screen, and that is a confirmatory test. But it's, problem is you gotta wait, I don't know, we'd have to talk to a pain clinic and see how they do it. But anybody have any comments? How's the pain thing going for you guys?
Yeah, we sent actually some preliminary data showing that we have substantially reduced the number of opioids being prescribed, so it's making a positive impact.
Right.
On that, Bruce Kay talked to me and she said 93,000 less pills, opiate pills in the last year.
That's pretty big. You know, nationwide we're like in the billions. But I mean, for our practice, you know, that would all add up. You know, yeah, some of the stuff's available on the black market, but now that it's harder to get pills, so people are turning to heroin, which yeah, is kind of interesting. Interesting, the last two cases of forensic cases I had of people that died of presumable natural causes, or causes other than drugs. Both were on meth. One guy was 62. Another guy was in his 40s. And one of the persons was having an argument with himself in his apartment, and then all of a sudden there was no more arguing. And a couple days later he was found dead in his apartment from multiple lacerations from a box cutter, where he had cut open arteries in his brachial fossa and popliteal fossa. So, and exsanguinated. So that's kind of it in a nutshell. It's the ups and downs, I guess, of drug abuse.
Have you seen any fatalities from the synthetic cannabinoids? Like the K2 and some
Oh yeah, K2 and whatnot. Yeah, the synthetic cannabinoids. No, I haven't. But those are hard to detect. You know, so it's hard to know if people have been on those synthetic cannabinoids. Now with 11 states having legalized marijuana, it's pretty easy for, you know, someone in that state to get a shipment without a return address. If you want to get the real stuff, that's kind of regulated and purified. But no, I haven't, to be honest. Yeah, and I think those are falling out of favor, really. The one opioid agonist that I was talking about, the kratom, is a plant that's ground up and put in a capsule, and you can buy that in bags from like a head shop, and it sometimes gets people through their opiate crisis if they're in withdrawal, but it's got some problems of its own. You know, it's sort of a naturally occurring opioid agonist in that particular fir. It's like a fir tree, and it's ground up into a green, looks like tea. Yeah, it looks like pretty much like tea, ground up tea. Yes.
Are drug screens witnessed in the lab when they're?
Some are, if they're ordered to be witnessed, they are witnessed, yes. Mm-hmm.
You have to specifically ask for it.
You do?
Yeah, there is, if you undergo under drug screen, you'll get 2 boxes. One is a witnessed. All the patients who are on Suboxone or on our maintenance therapy have to have witness.
We also have a collection devices with temperature indicator, and then, you know, we turn off all the stuff so it's harder to adulterate, you know, but witnessed are not frequent witness screens. Yeah, we only have like 3 males in the lab, and so I usually have Terry do it, or cytotech, or sometimes Tim, the lab director. I've done a couple, but you know, I'm usually doing something else, like at a meeting or wasting time at a meeting. Yeah. We're talking on the phone to a hospitalist. Just kidding, Samson. Don't feel like you're getting picked on, dude. Just, you know, you're an easy target, and I can see you.
Yeah.
So anyway, yeah, thanks a lot.